It's surprising how many so-called facts pertaining to clinical practice that everybody knows often turn out to be dead wrong. For example, have you ever heard a colleague state, quote, albuterol usually triggers tachycardia, unquote, or quote, a positive Allen's test is always preferable to a negative Allen's test, unquote. In this, the age of evidence-based medicine and evidence-based respiratory care, we should seek access to high-level evidence before accepting pronouncements upon which to base our practice. Alternatively, if a clinical practice can be shown to be based on bedrock physiology, such as the Fick equation or the alveolar air equation, its credibility can be ensured. Some RCPs, as well as physicians and nurses, maintain that albuterol commonly elicits tachycardia, but two randomized controlled trials, or RCTs, that specifically examined the incidence of tachycardia in the wake of albuterol administration found that the incidence of that side effect was very rare, being observed in less than 3% of cases. These studies enrolled a large number of patients, 362 and 836 subjects respectively, and their results are very convincing. Some practitioners rely on their anecdotal experience, but we present an example that demonstrates that this type of evidence is highly susceptible to misinterpretation. How about the reliability of devices that RCPs typically employ in their day-to-day practice? Is it appropriate to place our confidence in data supplied by an independent laboratory? Or are there rigorous requirements that should be imposed on data of this kind before we are inclined to place ourselves in harm's way? Have you ever substituted a mask for a mouthpiece when delivering an aerosolized drug to a patient? If so, do you have any idea if doing so affects drug deposition one way or the other? Precise evidence is supplied in this module that might surprise you. Have you ever had a physician request that you grab a gas 2 minutes after you change your patient's inspired oxygen fraction? If so, it behooves us to know how long we need to wait until steady-state conditions are restored and to pass that information along to the physician to whom the results are reported. Incidentally, the duration of time that must elapse before steady-state conditions are reattained differs depending on the patient's diagnosis, and you'll have hard evidence to share with your clinical colleagues after you complete this module. All of us were taught how to perform an Allen's test back in RT school. If and when you see a charting entry that reads, quote, positive Allen's test, unquote, how do you interpret that? Does that entry mean that it's all right to undertake a percutaneous radial artery puncture? In this module, you'll discover that it's distinctly possible that you were taught about Allen's test improperly. But don't feel badly. You'll observe that more than 90% of us were. Finally, how about the results of expectorated sputum samples? Lord knows we've all been assigned to perform a sputum induction procedure all too often. Is this even a useful exercise? In other words, when a sputum specimen is cultured in the lab, what % of the time does it yield a false negative, it's insensitive, or a false positive, it's nonspecific? You'll be provided with the results of a brilliantly conceived and flawlessly executed clinical study that will supply you with supremely credible evidence that you would do well to share with your physician colleagues the next time that one of them is inclined to write a sputum induction order. Your completion of this module will equip you to not only practice evidence-based respiratory care at a higher level, but it will also enable you to steer the RCPs, physicians, and nurses with whom you practice to hard data that will ultimately allow all of you to practice evidence-based care with enhanced confidence and credibility.